I'm Dr. Jay Anders, and this is Tell Me Where It Hurts, where we discuss some of the big challenges in health IT and how we can solve them so clinicians can do what they do best, care for patients. So I'd like to welcome everyone to another episode of Tell Me Where It Hurts. I think we have a very interesting guest today, as well as a very timely topic to talk about. And it's going to be along the lines of how you identify patients. And I'll tell you a little story from my past. I practiced in a town which had two very, very large multi-specialty group practices. My practice was about 125 members. The practice down the street was about 283 members. So it was very, very large. And one of the marketing things that we found that worked for our little small clinic compared to our big behemoth was they always, when you called them, said something very interesting. They didn't say, hello, who are you, or anything. What's your clinic number? Tell me your clinic number. We can't do anything in our system without your clinic number. So if I identified myself as Jay or Bob, or, the name wasn't acceptable, you had to have that clinic number. On our side of the fence, we would always ask their name and double check it when they came in. So it was a little more personal. And what we found is we actually had a lot of patients switch clinics simply because they asked for that number as opposed to ask for their name. So I found that very interesting, given the topic today, which is going to be centered a little bit around, well, in addition to this, but the major topic is a universal patient identifier and how that can actually help healthcare here. Our guest today is Mari Savickis. She has been working in the public arena for a very long time, including stints at the AMA, the CMS, the Office of the National Coordinator. Her passion is a longtime advocate for leveraging technology smartly, which I like smartly. She champions policies that improve the clinical experience for providers and patients alike and promotes innovation and competition. She's currently the Vice President of Public Policy with the College of Healthcare Information Management Executives, CHIME. She serves as the voice in Washington, D.C. for CIOs and chief security officers and other C-suite executives that are charged with the purchase and secure deployment of healthcare technology. She oversees the advocacy and interaction with federal agencies at the White House and Congress on behalf of CHIME. Mari, welcome to the podcast.
Thank you, Dr. Anders.
So, like I mentioned, you have spent a lot of time in healthcare policy at multiple levels. Tell me a little bit about, and our listeners, about how you got involved with all of your initiatives and what drew you to the position that you're in now.
Sometimes I ask myself that very question, Dr. Anders. Last year here, I'll tell a story, because to know a lobbyist is to know that we have to tell stories for a living. So my daughter says to me, okay, well, we're having career day last spring. I want you to come in and present. I was like, present about being a lobbyist? I was like, this will be hilarious. So I go in and I present to like the third graders, and I was like, okay, listen, here's the deal. I was like, do you know that it's illegal to sell lemonade on your front lawn? What? I was like, how many of you want to make some money this summer? And all the hands get raised. How many of you have tried to sell lemonade? A few more hands go up. I was like, yeah, you're breaking the law. And so I go into basically how a law is made. And so you would have thought that I may have had some sort of lifelong ambition for this, but I guarantee you and your listeners that no child ever says when I wake up in the morning, you know what, gosh darn it, I'm going to be a lobbyist when I grow up. Said no one ever. So I kind of think I fell into this. I don't even think I was like paying attention in social studies. And then I get to college, and I was supposed to be an art major. And you know what, I was like, the art director was a jerk. And I was like, I'm going to take this other class. And I got an A in politics and government. And I just never turned back. And so here we are. You said a very long time. Let's just say like many years later, just still in public policy, love it. And I'm one of those weird people who devours federal regulation for a living. Total snooze fest, right? I mean, you do have to kind of break it up with like a few cups of coffee when you're reading federal regulation, but I like it, and I enjoy it. And you asked about like how did we really get here, and I'll just say that back when I worked for CMS, they were just starting to implement HIPAA. Okay, now I'm totally aging myself. I get that. But if we can all go back in our time machine, HIPAA, right? It was about portability, but it had a bunch of stuff in there. It was really the precursor to health IT. It was the administrative side of healthcare, and rooted it in there are 4 identifiers. And I just remember taking all the phone calls from all the angry doctors. If I have to do this HIPAA stuff, I'm going to like quit my practice. I can't tell you how many calls I took like that at CMS. Many. I got to punt though. I was like, oh no, privacy. Yeah, that's not our jurisdiction. That's OCR. So I totally got to, punt them over to a different phone line. But I will say it goes back a long time. And then, in 2000, I think it was 4, President Bush comes in and he says he wants to do something on health IT. I raised my hand. I was like, I'll go volunteer at ONC. They have no funding. Let me go, Medicare. And they say, yeah, we'll lend you to ONC. This like newly concocted agency we really don't know much about. And I spent a year there and I absolutely loved it. So, ONC really built upon the backbone, which I'm sure you're intimately familiar with as a billing executive. It built on that administrative stuff, which, by the way, still isn't totally figured out. Ask any patient or doctor about prior authorization, and they'll probably want to, wring a few necks. So that's really how, I don't know. I like it. I love it. I pretend like I'm a lawyer half the time. I'm not, but here I am.
Well, I have to agree with one thing. One of my responsibilities in several different organizations have been reading new federal regulations, and it definitely takes a cup of coffee or two and some time to get through them the way they're written. But it's so important to have somebody to really read them, because you don't ever understand them until you really, really read them. So interestingly, along those lines, TEFCA has recently come about, and it appears that interoperability is actually going to occur in some shape or fashion. So in your experience going up Capitol Hill and talking to folks, what can you tell us about the discussions of how that actually got going and how we kind of broke through? Because the way I see it is that until the federal government decided that we are going to have a policy and a set of rules, and here's what you can and can't do, that interoperability was never going to happen. Sharing of medical records, we're going to be stuck in HIPAA land, meaning I can't do it, I can't share it, I'm going to go to jail if I do. That was kind of the way HIPAA scared a lot of providers, at least at my level. You didn't want to share anything unless you absolutely had to. So tell me a little bit about how that process went about or came about, if you can.
Yeah, I'd be happy to. I mean, and that is like you just touched on something that's like this notion of, don't overshare under HIPAA, which has been ingrained into the provider psyche, provider/clinician psyche for the past several, decades. And now we're pivoting to like, you must share everything. And they are and they are not diabolically opposed, but it's really hard to change that muscle memory because, I mean, as you and I both know, the doctor isn't sitting on at the front desk, right? It's somebody, a receptionist or someone, and you're saying, no, I need you to like show this. No, we can't do that because of HIPAA. We're going to try to not educate all the clinicians in the country, but all of the frontline staff. I mean, it's a lot. So to answer your question though, about how did we get here? Okay, so we got HIPAA, great, that's great. And then we have, again, 2004, we want to move towards EHRs. Most hospitals and ambulatory settings did not have electronic health records. Dr. Brailer comes in, under leadership of President Bush, and he says, okay, we're going to change that. So then they get some funding, right? AKA high tech. That was under, again, I'm going back in what I call the policy time machine. Everybody strap on. 2008, remember, it was a recession, not so good. And they were looking for shovel-ready projects. And, included in that big ARRA, and I'm trying to American Reinvestment and Recovery Act, can't believe I can remember that. But under that ARRA statute was high tech. And high tech had incentives for hospitals and doctors to purchase and deploy technology, of course, with strings attached, right? In a lot of cases, downside risk if you didn't do it after a certain amount of time. And so that they went through that whole process, right? So, okay, so now most hospitals, most doctors, great have EHR, super awesome, amazing, and they're certified. So there's some base level of understanding about what they can do, but still to your point, the data is siloed. Everyone's their own island, each, island for itself. And it's brutal. And data sharing is still very nascent. Interoperability, that overused word, it's fledgling. And Congress is sitting here shaking their head, and many others saying, like, geez, we just dumped all this money in, but it's still not where it needs to be. So then along comes the effort around 21st century cures, which is an enormous piece of legislation that, again, includes many other things not related to health IT, but includes health ID, right? It has a piece in there. And here we are with the Cures Act. So if you haven't heard about, your listeners are like, what is she talking about? And I think it was passed into law. Oh my gosh, Cassie might have to correct me here. 2016, maybe, several years ago.
Sounds right.
Either way, It's now, it sounds about right. Hopefully no one's going to go spot check me on this. 2022, here we are. And the chickens have come home to roost. Okay. It's time to get going and implement stuff. And people are like, what the heck takes so long? Well, let's go back to my analogy about selling lemonade. You have to go through a process, right? You have to go get a law passed. Then you have to punt over the law to the appropriate agency or agencies, and then they have to do rules. And first, before you finalize a rule, you got to ask for stakeholder input. Many years later, and plus inside our time frame is a pandemic, which of course has slowed things down. But here we are. The next deadline is coming up. So that was sort of the timeline. But Congress realized just because you have a certified EHR does not mean that we have ubiquitous interoperability. So TEFCA, Trusted Exchange Framework and Common Agreement, that rolls off the tongue, right? Go Google that too. If you don't know what TEFCA is, just say TEFCA. People know what you're talking about, at least here in DC. And so here we are back at, we have to start implementing these things. And, you asked about Capitol Hill. There's only a handful of staffers on Capitol Hill who have any idea what TEFCA is. There's key committees of jurisdiction who are deeply rooted in this, but even those committees of jurisdiction, they have staff that know this really well. And we know those people, but there's a Senate Health Committee and House Energy and Commerce, right? Those are two examples. When it comes to incentives, it's Senate Finance. So there's a very finite group of people, and Cassie knows them all really well, who do this for a living. And so these are the people, the architects of the statute that we now are in the process of executing today. And if you're a provider listening and you don't know what October 6th is, go Google that too. Otherwise, you can just email me at the end of the program, and we'll have a therapy session. So October 6th, right? This is when EHI, you're like, wait, you're giving me another acronym? Oh my God, I can't take that. So HIPAA had its own lexicon. That's right. Get your dictionary out. We have a whole new lexicon for the information sharing. We got TEFCA, we've got, EHI. The list goes on. And we've got RCE, not REC, not to be confused with REC. And here we are, Dr. Anders. What are we going to do? How are you handling this? Are they ready? Is anyone ready?
I'm of the opinion that, I call it enter without operability. We've been sharing medical records for years, meaning they go in a big folder. They are faxed. They are transmitted in some shape or fashion to another location. The problem is it's a big pile of stuff going into another big pile of stuff. And we can talk for hours on that to give, some type of usability to all of what's being exchanged. But one of the very interesting things, and it's been absolutely one of my soapboxes for a long time, and I've been a reviewer for HIMSS for 5 or 6 years now. And every year there are people presenting at HIMSS that talk about schemes to identify a person, to make sure that Jay Anders is Jay Anders, that they got the right guy. And if you Google my name, there's a lot of Jay Anders out there, and I didn't know that, but there are. So how do you figure that out without some kind of unique thing going on? So here we have, at least in the HIMSS world, a bunch of very, very smart people using all kinds of fuzzy logic, locations, past addresses, phone numbers, how many children you have, you name it. I've seen every permutation of your life that you can imagine that would figure out who you are, when the answer might be fairly simple, is having some unique number, and it can't be your social security number because that's linked to who knows what now, especially your credit rating and other things. But there's been that kind of pushback on actually creating something that would allow my medical record with code 123 gets transmitted to another place with code 123, and they know it's me. So could you talk a little bit about that? And I read a couple of things where the cost of not having this is monstrous in the US healthcare market. Hospitals spend a fortune doing it. The US healthcare system as a whole, Medicare spends a fortune doing it. So can you talk a little bit about what you're seeing in that regard on Capitol Hill and how that is expanding, contracting, pushback, people for it?
Yeah, I would be happy to. My dad's name is Eric Johnson. He's been on flights before where they're like, even the same middle initial. I mean, he goes on a flight and maybe ends up in like the wrong place, like not the end of the world. You misidentify a patient and you're talking about life-threatening, if not deadly outcomes potentially. Maybe there's some healthcare fraud too. So there's problems there that are greater than getting on the wrong flight. And yeah, so let's go back again in our time machine. So again, standards in HIPAA, you have the patient identifier, you have the provider identifier, which every clinician in America has a national national provider identifier, aka NPI. Then they had national payer. That one, went to the wayside. I'm not sure they could ever iron that one out. Probably the least important of all the ones we're talking about. And then I think there was like the employer identifier, which is like EIN, I think. But the patient one, okay? So Senator Rand Paul Sr., many years ago, decided he didn't like this idea. He felt it was an infringement upon people's liberty and privacy. And so he took it upon himself to say, no, we're not going to do this. And he was the real barrier in Congress. And then his son, the current senator, took up the torch and has continued to say no. So what we have here is a real obstacle on the Senate side, and this continues to be a challenge for us. So we've gotten pretty far with the Democrats moving this ball forward on the House side, and even potentially some Senate Democrats, but we just haven't been able to get this over the finish line, and that is, he's not going to stop being a barrier, and many won't go up against him. So here we are without, and you're saying, well, what does this all mean? Well, basically, this ban that has been in place, established in 1999. Oh yeah, 1999. It wasn't even like 2000. Says, listen here, HHS, it's part of your annual appropriation. We call it in here in our DC bubble, we call it the Labor H bill. It's the appropriations for Department of Labor and Health and Human Services. And it's a big nut, right? Just like defense and education, we have all these other ones that get funded, agriculture, so on and so forth. Well, for the appropriations for healthcare stuff in the federal government, they said, listen, you HHS will never, ever touch this topic so long as, this ban is in place. So you can't spend even a penny, not one red cent, on establishing a standard for a patient identifier. So that's why, and it remains, and it gets renewed every year, just like clockwork. And while you can win a few battles until you win the war, and we're not close to winning the war. I'm not going to say that we are, because we've won a lot of battles, right? Like I said, on the House side, but you have to win that war, and that barrier, Senator Paul, still remains a big barrier. So that is why we do not have the ability for HHS to set standards. And if you're in the health IT space, standards are everything. It's interoperability, right? If say date of birth is coded with the year is four digits versus two, then we got an interoperability issue and garbage in, garbage out. So that is why we have all these organizations who have to take it upon themselves to figure out their own strategy, like algorithms and referential matching and all those other things, and there aren't even standards around those. And so that's why we are where we are. Does that answer your question?
It does. It does. And I find that fascinating, given the fact he's a physician. I mean, if anybody would know that the fact that's how important that is to get it right the first time, that is amazing to me. I can't quite understand it.
Well, I think prepare to be admitted to this Washington, but that's the reality. And so, at this point, I think that I have just had to take a hard look here. And I'm all about, if you can't go through the mountain, you go around the mountain kind of thing. You go over the mountain. We have to figure out a different way, right? I mean, we're going to lay down our sword and stop fighting the battle to remove this provision. It's again, I don't know if your listeners care about the provision 510 and the labor H bill, whatever. It's just this provision that prohibits HHS from spending any money. So if we can't win the war, then we have to look at other ways to help solve the patient safety issue. Whether or not we have this physician in Congress who believes that this isn't the right way to do it. So that is something we're taking a hard look at. And I don't think that there's one solution per se. No. I mean, you could bring again, for example, and let me just reference, maybe, I don't know if you'd share links at the end of your program, but we are part of a coalition, okay? And just all your listeners out there, there's no fee to join the coalition. It's organization though, it's not person. So patientidnow.org, you can go look it up, patientidnow.org. We lead this organization with some other organizations like HEMA and some others, and we try to change Congress's mind to flip this over. But there's a lot of discussion around the cost. You asked about costs and challenges. And while we continue to go down the road of trying to remove this, Cassie and I, my colleague, who really, again, spearheads many of our efforts on Patient ID on the Hill, are looking at some other options. And the Patient ID Now Coalition, for example, has put forward a framework, like things that you should think about that don't necessarily involve a patient identifier. Putting privacy first is a thought. There's many things in here that we talk about: the cost, the administrative burden, the safety impact, the disparities on those who don't speak English. There's so many problems with this, but we can't sit around here and hand wring. I don't have time for hand wringing. And I think we've hit a wall where we're like, okay, we got to look at some other options. So other options might be, for example, there's a provision that was part of the CHIPS Act, and I'm no Intel processing chip expert over here or any vendor that makes chips, but there was a big piece of legislation that just passed earlier this summer that puts money into helping put America first as opposed to China on chips, computer chips. You might say, well, what does this have to do with anything? Well, inside of that bill is a provision related to digital identity. And we've been watching that, okay? Digital identity, okay, the way to be identified in the ether. We're online all day long. Banking has figured it out. Big platforms that sell to us every day, that we buy from every day, have figured this out. And so how do you identify somebody in the ether so that that it's you, Dr. Honors, the right J.R. Honors, that it's not, maybe your colleague down the street who happens to have the same name and birthday as you. So there's a digital identity provision in there that we're following, and NIST developed standards. I've just learned recently, and I got to dive into this, that California mandated a national identifier. It's on my to-do list. Going to look that up. So we're looking at different ways, and then maybe bringing some standardization to maybe the algorithms. And finally, and again, this isn't even finally, I'm sure there's other ideas, but we're collecting them. So send me all your great ideas, is more transparency for vendors. The certified vendors don't actually they're not forthcoming with what their match rate is. So if you go and ask your vendor, like, hey, vendor so-and-so, could you tell me what the match rate is for patients? They'll kind of hem and haw, and they don't want to give that information out. We'd like to see a bright light shine onto that so we know a little bit more about truly what the mismatch rate is. It's hard to, solve a problem when you don't have all the information right in front of you. So those are a few things, and I'm sure I'm missing stuff. So maybe Cassie will help me if there's anything big that I've missed, she can pipe in here. But does it make sense? Like we can't go through the mountains, so we have to figure this out.
No, absolutely. And I'm all for that. And that's why I was curious when I was reviewing these proposals, how many different ways. And you're right, there's not one really great way, but as long as people are obstinate, we have to find a way to get around the obstinance. It's a simple fact. I personally believe shining a light on what you just talked about with match rates, shine a light on the medical errors that are caused by mismatch and how that works and what those are. Because there are some things you can put in a medical record that could harm a patient very, very badly. And we've got to make sure that, it is what it is before we start to act upon it as a clinician. So
I forgot to tell you, I can't believe I forgot this, but we had patient ID week last year, and you mentioned patient harm. It's really hard to find patients who are willing to go on record and say, I was harmed. I'm raising my hand. I was harmed by being mismatched with someone else. Either they don't know about our effort, or maybe they're under some sort of like agreement where they can't talk about what happened, but that is a really big issue, right? So we are looking for people who are willing to tell their story, because let me tell you something about Congress. Here's another thing. How many legislators do you think are aware of this issue? Right? I mean, if you explain it to them, though, right, not that many. If you Representative Foster has been a big champion of ours, and he's been doing some great work, and Representative Kelly. But here's the thing: patients may not know that there's a whole effort in like all this sausage making stuff that goes into this. So we have a patient ID awareness week, and patient ID day, and so if you want to help get the word out about, or of a patient who's been harmed, please give them our email so we can talk to them in confidence. We don't like to give up people's information, but it's so hard, right, to find these, and that's how you win the hearts and minds of lawmakers. You tell them a story that they can relate to, right? That's what we need.
Well, I'll certainly be on the lookout and help with that, because I think I do know a few. So we're kind of cutting down to the end of our time here. I ask this question of every guest. If you could wave a magic wand and change just one thing in healthcare IT, what would it be? I think I know what your answer is, but go ahead.
Oh, golly. That's a good one. Well, I think it goes back to what I said I'm passionate about is, you want the efficiency, right? I remember, if you again go back and think of those harrowing days where meaningful use, when it was still called meaningful use, said, oh, print the summary for the patient and give it to them. And all the doctors give them the patient the summary, and they summarily throw it in the trash, creating a seemingly HIPAA violation. But that was, again, we don't need a million pieces of paper in the garbage. We don't need CCVAs that are voluminous and no one could read them, or you just turn them and doctors' eyes glaze over and then they just start deleting everything in their inbox. No, we don't need that. We need efficient, right? And so it has to be like efficient. It has to be meaningful. It needs to meet the patient where they are. It needs to meet the provider, the clinician where they are. So it has to be efficient, effective. I mean, yes, interoperability is obviously core to this, but it's just having smart technology. I used to say, like, doctors aren't opposed to technology. They just want good stuff that works, right?
Absolutely.
And patients, they don't really care how you got there. They just want to be able to like get their record. They don't want like the millions of reasons why you can't do it. Just give them what they need. So it has to be more efficient and meaningful. That's what I would say.
That's a great answer. And that's pretty much what I'm about these days in what I do every day. If people want to get more information, now you did mention your website, the website about the patient ID. So if they want to get in contact with you or your organization and see what you're about and see how they can help, how would they do that?
Yep. The teams, it's a phantom email box. Don't get deterred by a phantom email, because let me tell you, there's only a few of us. We're small but mighty. policy@chimecentral.org. Let's open the door to a conversation. You don't have to be a CHIME member to have a conversation with us. We talk to many people all day long, just like you. And we will talk to you about your plights, your woes. We'll break down the tough stuff. We'll, and it's, what, it's okay to agree to disagree. It's okay,
Absolutely.
right? We don't all
Yes.
have to have the same opinion. And I like to hear everybody's opinion. So that's the best way to reach us is policy@chimecentral.org.
Well, Mari, thank you so much for joining me today. It's been a great conversation, a lot of really great points, and I hope it's been informative to our listeners. Again, thank you so much for being here.
Thank you very much. Happy to do it.
That's all for today. Thanks for listening to Tell Me Where It Hurts. Tune in to Healthcare Now Radio and Podcast Network each month for the latest episode. To learn more about Medicomp systems, visit our website at www.medicomp.com. You can also follow us on Twitter at MedicompSys or myself at MedicompDoc, or check out the show notes for links. See you next time.